So you could always add skills. These are some examples of skills you could add, and if you added skills, again, the skills would prevent the problem behavior from occurring, right? And then you could change the consequences. So from a DBT point of view, impulsive, emotion-dysregulated behavior, 90% of the time, the short-term consequence is reinforcing, the long-term consequence is a disaster, right? If the short-term consequence was not reinforcing, you wouldn't do it again. The long-term consequence wasn't a disaster, we'd call it skillful behavior and we wouldn't be treating it, right? So this is the kind of pairing you're usually going to see, okay? So, this is just straight behavior mod. Understand what reinforces the patient, block reinforcement for dysfunctional behavior, up the reinforcement for functional behavior, and put reinforcers on time versus crisis behavior if you can't stop reinforcing it altogether. So if contact with you is reinforcing, you aren't going to stop that because they're dysfunctional or you'll never get control of the problem. You can at least put it on a time schedule and rather than a response to crisis schedule. And it's really no different than any other behavior program. You can change other links. There is cognitive modification in DBT, even though we all pretend there isn't. So you can do cognitive modification, teaching them like to surf the urge, sort of kind of a Marlatt idea of helping them to be able to ride out these intense urges. I teach buying time strategies, like just being able to make a graceful exit to the bathroom long enough to get yourself into control before you keep talking. It's something you're really going to regret. Figure how to set things up.
I didn't know that was one of the things that you really emphasized.
I do.
Every time I say that to my group, they say, "What? Go to the bathroom?" It's like they've never heard it before. So I'm really
yes,
happy.
well, I don't know if I've gotten to it with my current patient, but I'll make sure I get to it.
She does it.
That's right. I do it. I tell them.
Yes, I do it myself.
In fact, I gotta go right now.
Setting the alarm on your pager so that you can get out at the time you need to. Yes. No, you can be strategic about these things. So the basic idea in DBT, from a change point of view, is that you're staying very closely to this linked chain of events. The chain of events is probably, maybe it's hours, but frequently it's literally minutes, and you're kind of choosing the best bang for the buck to get those skills in. And I think this is really critical because a lot of behavior therapies do functional analysis of one kind or another, but often it is, if you've really got an emotion dysregulation problem, like in FIT, for instance, I think FIT circles are amazing, and we've talked about using them more in what we do. But when it comes to stopping a specific impulsive behavior, it's not the way to assess the problem, right? You've got to assess really, in a short window of time. So you just that's an important part of DBT. Another thing in DBT is dialectics and validation, right? Which is more than typical radical behavioral therapy. So this is my oversimplified version of dialectics, which is essentially what we're trying to find is the synthesis between a thesis and an antithesis, right? So basic kind of dialectical philosophy, wildly oversimplified, is that instead of a positivist notion where there's one right and everybody else is wrong, or a relativist or social construction idea where everybody's right, in DBT, we do think some things are more right than others, in the sense that some things are more useful, effective, reasonable than others. And that, in fact, what you want is to find the most reasonable by recognizing that for every thesis, for every idea, there's going to be an opposite. And the goal is to find a way when both of those are true, right? So going from either or to both and is often the easiest way of thinking about it. So in DBT, the primary dialectic is between this idea that you must accept yourself exactly the way you are, right? And you must work as hard and as fast as you can to change. Right? This is kind of the key idea in DBT. So validation and mindfulness strategies are used to help people accept themselves exactly as they are, and behavior therapy is used to help them change. And there's lots of other behavior therapy, sort of dialectical behavior therapy patterns, right? Skills acceptance, getting more skills versus acceptance, problem solving versus problem acceptance. One of the things that's important in DBT is that we don't always think that the first thing to do in any given situation is fix it. Some things are not fixable, some things are not better fixed, some things are better accepted. Affect regulation versus affect tolerance. So the idea that in order to not do an impulsive thing, you must feel better, right, to actually regulate, right, as opposed to sometimes you've just got to tolerate that you feel like hell. And that does not mean that the best thing to do is then, drive your car off a bridge. Independence and dependence, and then this is one of the dialectical targets we have for adolescents, pathologizing and their families. Pathologizing normal behavior versus normalizing pathological behavior, right? Both of which the families of the kids in our programs typically are doing. There's a number of these other ones built into the adolescent model. So we also have a lot of dialectical strategies. So I'm not going to teach all of these, but these are things that we do in the dynamics between ourselves and the patient in individual or group or on the phone coaching that's designed to find that synthesis. Because it's very easy for you and the client to get into, where it's just you and the client or you and the family, right? And the idea is that we want to go from this to saying the problem is out here and we're together fighting it. We have to come to a synthesis where we can see that we're both right, and there's some way we can see our situation that makes us both right. And there's a lot of other DBT strategies I can't tend to go into in this short period of time, but that sort of use this dialectical strategy in terms of what we call our communication strategies, which is the style of how a DBT therapist interacts with patients, our case management strategies, which is the idea an environmental intervention is where you take care of the problem, right? So this patient needs new housing. And so you get on the phone with Seattle Housing Authority and you figure it out, you get them new housing, right? So the idea is that you're intervening in the environment on the patient's behalf. In consultation to the patient is where you are consulting with the patient, so the patient intervenes on their own behalf. And essentially with a complex and extreme case patient, you'll never get control with environmental intervention. Something will always fly apart at the seams. Anybody who's been in these meetings that take 3 weeks to get together of every player who's ever dealt with a kid, and you come up with a great plan that falls apart within like the first 5 days after this meeting, knows this will never work. And the basic idea in DBT is you've got to teach the patient to do this themselves. You've got to get them to manage their treatment environment or forget it. It's never going to work in the long run. But sometimes you do need to do an environmental intervention, and obviously more for kids who are, unable to make, they don't usually get to redecide their foster care situation and negotiate with their DCF worker all that much themselves. So there are some things you may need to intervene. And then validation. So I just want to point out, this is really a big part of DBT. I think a lot of good therapists just do this naturally as part of building rapport, but a lot of good therapists don't validate naturally when they have a complex and extreme patient who's pissing them off or scaring them. Usually validation goes completely out the window when you yourself become dysregulated. So in DBT, the fact that we have this explicitly, I think, is really, really important, and it's key to working with very difficult kids and difficult situations. So you're going to communicate, it's about communicating acceptance, finding the kernel of truth in the other person's position, finding that both and, believing that they have a position that makes sense. And you have to believe it in your gut, and you've got to communicate it to them. And also your belief that the client can get out of this misery and create a life worth living. And we do a lot with, like this, it sort of breaks my heart with these kids in the Connecticut residential system, but I have had to really, as we say in DBT, radically accept that these DCF workers in this system will not send them home. They are going to age out of this system, and my best hope is to get them not to go immediately to the adult mental health system, which is what everybody's doing next. And for me, that took a lot of acceptance, because I think these kids could be with families, and just drives me berserk that they aren't. But the reality is that they want a family, and everybody says they're never going to have one, and I spend a lot of time saying, I'm 43 and I have a family, so you can have a family even if it means, they get sort of locked into the world of do I get to live at home with, you know, when you're 18, you can do whatever you want. I mean, the majority of these kids do go back to their